Hello, my name is Ewan McGahey, and today in Enterprise Law we are doing the healthcare system. So I'd like to start with this quote from Nye Bevan, Minister of Health in 1946, who was talking at the foundation of the National Health Service in Britain. He said that money ought not to be permitted to stand in the way of obtaining an efficient health service. It is repugnant to a civilised community for hospitals to have to rely upon private charity. And what he's saying is so important in so many ways because not only was there the principle with the NHS that's been followed by countries all around the world, that healthcare should be free at the point of use, that health should be treated as a fundamental human right open to everyone regardless of money, but also that money, if it is in the health system, gets in the way of the delivery of an efficient health service. Not only is it an obstruction for people who need health services, but if you want to have an efficient healthcare system, then private profit and the making of money from people who are sick is, repugnant to a civilized community, as he also said, and it gets in the way of an efficient health service. Good health, we know, is essential for a fulfilling life. It's essential for people to work, and therefore it's at the foundation of a successful economy to have a healthy population that lives long, quite apart from the basic things that we all care about of living fulfilling lives, being healthy and happy. But there are core issues that are still debated about healthcare's function, how healthcare is financed, how it's governed, and the rights operate in it. So key areas of clash that are still debated are, firstly, the extent that private profit should be allowed in the provision of care, in building of hospitals or other buildings, and in the provision of medicine and drugs. Secondly, the extent to which staff or patients should have voice in the governance of a health service. And thirdly, things like the role that litigation should play in enforcing rights to healthcare. So we're going to go through all of that. Firstly, on the history, the human rights and market failures related to healthcare. Secondly, how the health service is financed for hospitals, general practitioners, for drugs, and in preventing ill health from transpiring in the first place. Thirdly, the governance of all the institutions that we see in the healthcare sector, including care boards, hospitals and regulators. And fourthly, the rights that people have to specifically get healthcare that they can enforce in court. When we look at healthcare, unlike education last time, we see a huge shift in the technology that is available for modern medicine and is at the disposal of doctors and surgeons. If we go back to ancient times, we see very limited sort of superstitious theory about four humans. We'll get to that in a second. It wasn't until 1796, after centuries of human history where people are really at the mercy of nature and diseases and viruses, for the first time a vaccine for smallpox is invented. It wasn't until 1928 that you had penicillin, an incredibly important drug, and today we've got the rapid development of all sorts of health technology. AI is being used to diagnose diseases at more early stages. We've got, we understand DNA, there's the growth of personalised medicine, and it really seems like the only boundaries are based on how much we actually invest in innovation research, because the trend of scientific discovery and research is exponential. But before we get to the future, what we need to look at is the past. So let's first of all start by going through some history of the healthcare system. When we go back to ancient times, you had pretty advanced ethics in the same way as actually education is functioning in certain basic forms in the same way as it is today. The understanding of what doctors and surgeons should do in ethical terms is pretty advanced. Everyone has heard of the Hippocratic Oath. Hippocrates was a writer in ancient Greece, and in his corpus, his oath says that teachers of health and medicine should be held in esteem. Less known is that people should teach students without students paying fees. and the goal was to help the sick, and the thing that everyone remembers is to do no harm. Hippocrates, however, was he constructed his theory of medicine on what we now know is a completely flawed scientific basis. Galen, a famous medical author in the Roman Empire, in his corpus, followed Hippocrates with this idea of the four humours, that the body is composed of black bile, yellow bile, phlegm, and blood. When these four humours are out of balance, that's what is causing sickness and ill health. Sort of like the very primitive understanding at the time of nature and the elements wind, fire, earth, and water. These theories weren't debunked for centuries to come, not until 1543. And in these times, people were really at the mercy of all kinds of viruses and diseases. Life expectancy for most of human history was, for most people, something like between 30 and 40 years old. We had the Black Death, which killed about a third of Europe, half of London in 1347. Plagues constantly, bubonic plague, constantly recurring. Another big one swept through London in 1665, the famous plague. And what did people have? Well, they thought that they could breathe in the scent of flowers, not like this one, this is a rose, but posies, and that might make them better. And of course it was absolute nonsense, because germs don't respond to miasmas and poor smells. It was the case, however, that after the Plague of London and the following on from that, there was another tragedy, the Great Fire of London, that there was a rebuilding of all the streets, and one of the a conscious attempt was made by architects to ensure that London's crammed alleyways were opened up to make the city somewhat more spacious, and big plagues did not recur as much after that. But what we also have around this time is the growth of institutions devoted to healthcare. So, it's really a medieval creation. You have St Bartholomew's in 1123, St Mary's in 1347 near Paddington. St Thomas's was founded in 1693, so not long after the plague and the Great Fire. Guy's Hospital, which is now part of the Guy's and St Thomas's National Health Service Trust, was founded in 1724, and I should mention a lot of it using the money made by Sir Thomas Guy from his investments in the slave trade, the South Sea Company. St George's was founded in 1733, London Hospital 1740, Middlesex 1745, and so on and so on. So these institutions, they mattered so much because there were places at which doctors and specialists could congregate, they could share ideas, and even if these hospitals weren't really doing much to counteract the enormous suffering that most people's daily lives were filled with, what they were is cauldrons of innovation where new ideas about what brings us to modern science, modern medicine, could develop. There weren't many institutions that dealt with public health on a more broad basis. I mean, these hospitals, these institutions were primarily charitable, or they catered for the very wealthy. You had something called the Poor Law, which provided sort of basic welfare, very, very basic welfare protection. The Elizabethan Poor Law Act of 1681 was designed to give relief, among other things, for the lame, the impotent, the old, the blind, and those not able to work. But most people are living through grinding poverty and die very young. So it's not until, as I mentioned, 1796 that you get the first Edward Jenner discovers the smallpox vaccine through his practice in Berkshire. He was working before that at St George's Hospital, and it's Alexander Fleming who discovers penicillin on a petri dish in the hospital in Paddington at St Mary's, not until 1928. So modern medicine is something that sort of slowly creeps up at the end of through the 19th century, early 20th century. The really big strides that were made were not yet through hospitals, but were through public health measures. So the big change was the 1848 Public Health Act, which focused on ensuring that people had a clean water supply. And as we'll see more of when we do water, this was off the back of the discovery of cholera, or what cholera was and how it was related to filthy, sewage-ridden water sources in Soho just a few years before. And the public health acts are really what drove, as we'll see in a second, some of the major advances in human health. The 1875 Act followed that, required that there was running water and houses had access to drainage. The 1904 Act tackled filthy housing. It created duties on landlords for their tenants' health. And so these are really what drove big developments in public health improvement. There wasn't anything to ensure that people had access to medical care until the National Insurance Act of 1911. And what this did for the first time is through people's employers, and therefore, if you're a woman, usually through the male breadwinner and their employment, people contributed to the National Insurance Fund and got some limited cover for healthcare through that. Most health insurance was done by big private companies. Prudential, Liverpool, I think that's Liverpool, Liverpool Victoria, I beg your pardon, I think it's Livery Victoria, Pearl, and you had these armies of insurers, agents, and collectors that essentially tried to make a business on squeezing as much insurance money as they could out of people who were poor and sick. The Ministry of Health was only created in 1919 after the First World War. But now let's attach some of the story to some statistical change. So what this chart shows, quite striking, quite dramatic, is life expectancy from 1840 up until 2020, and that is the dark blue line that's going up. And in the other lines, the blue, light blue dotted line, and then the undotted line, because they're different sources, one's for the UK, the other one's for England, Wales, this shows infant mortality going down. And so you can see that in the 1840s, the average life expectancy for birth was just over 40. And of course, in different regions of England, it could be much worse. If you're a Liverpool miner, the average life expectancy was still 30 or thereabouts at the turn of the 20th century. But life expectancy is steadily going up and up and up, really from the Public Health Act of 1848. That was a really big change that shifted the trajectory of human history so far as life expectancy was concerned. Infant mortality, so deaths in or shortly after childbirth, really start coming down with the Public Health Act of 1904. And we can also see significant improvements in infant mortality when public hospitals are fully funded through the National Health Service Act 1946, and everybody has access to healthcare, free at the point of use, not bound to an employer. That's why you get a significant improvement in the what were appalling infant mortality statistics. So now we're about 2 or 3 deaths per, I think it's 1,000 births. Okay, so that's the sort of trajectory through the statistics. When we get to the 1946 National Health Service Act, it's important to see what opposition the Labour government and Nye Bevan, who is the health minister, what opposition they faced to get through this idea that health should be free at the point of use. Because remember, from the National Insurance Act and the system that it kept intact, you have these armies of insurers. And you also have significant opposition from the medical profession itself. And Bevan famously said that in order to overcome the opposition of the doctors, Bevan had to stuff their mouths with gold. He won, and the National Health Service was created, and it was administered through 14 regional health boards. And, in its basics, the National Health Service is pretty much the same as it was in 1946, except for the fact that it's gone through many, many changes of governance, of administrative organisation, seen through a successive group of acts. And it almost seems like every government that wants to come in, that comes in, every new government that comes in wants to reorganise the NHS in some new funny way. So you've got the NHS Reorganisation Act of 1973, where regional health boards are turned into regional health authorities. And then there are also local authorities' powers, local health authorities' powers being transferred to what are called area health authorities, and 90 of those, and 205 district health authorities, which later take over the area health authorities' functions. What is the role of the staff in this system, or what is the role of patients? Well, that was really debated properly for the first time in a white paper called Democracy in the NHS. I shouldn't say the first time. Bevan was definitely interested in this topic, but government proposals were put forward in 1974 in the Democracy in the NHS paper. It talked about how patients could be more involved, how staff could be more involved, but because there wasn't significant enough agreement, the only provisions that were there were for local councils to get more voice in the governance structures of the NHS at the time. In 1982, the NHS is reorganised again, as I mentioned, area health authorities being put into district health authorities. And Margaret Thatcher's government didn't do with the NHS what she did with many, many other enterprises like telecoms and oil and the military hardware companies and railways. She didn't privatise the NHS, but there was a significant sort of backdoor privatisation in the NHS Community and Care Act 1990, the creation of an internal market so that everything in the NHS had to be accounted for through prices, modern accounting, and that they could borrow. Some good elements of that, certainly to keep track of money, but the internal market meant that there would be less cooperation over the NHS as a whole. And a really big step was made through the NHS Private Finance Act of 1997. It was one of the last things that the major government put through before they were defeated in the election, losing to the Labour government. But the Labour government continued this idea that if you want a new hospital, then you can do it through private finance, and the hospital not being built by the government is owned by it's owned by the private sector, or rather I should say it's run by the private sector, and the government rents it out from the private sector at a very significant cost, paying off in the future. So you've got PFI, you've got the internal market, you also have private bidding for NHS work. This doesn't take off significantly until after the 2012 Act. You've got another reorganisation under Labour. Health authorities are transferred to what are called primary care trusts. But then the 2012 Act projects another wave of privatisation. So that primary care trusts can do, there was a cap on 2% private work before, and this cap is raised to 49.99%. So just as long as they do half or more of NHS work, that's fine, but they can do almost half private work from the 2012 Act onwards. There's also the creation of NHS England, which is supposed to be an arm's length non-departmental body to take functions away from the Department of Health. In practice, NHS England just replicates many of the things that the Department of Health has done because it's not properly thought through. Primary care trusts after the Act are transferred to what are known as clinical commissioning groups. There's 205 of those. And then there's another reorganisation at the end of the Conservatives' time in power to transfer clinical commissioning groups, which have failed for all sorts of reasons, into what we now have, which is called integrated care boards. The new Labour government, since 2024, has abolished NHS England again, or announced its abolition, and it's going to be merged back into the Department of Health. So there's been this constant process of reorganisation, and I think that speaks to the fact that the theory of how governance should be run in the NHS is not really that settled, and politicians are not drawing on a coherent set of ideas about how something as massive as the National Health Service ought to be run in order to get the most value for money and to get the best outcomes for patients and the public. Now, the NHS is one of a number of different kinds of systems that we look at around the world. It's free at the point of use. It's organised primarily by the public sector. It is owned by the public sector. But the other systems that we see around the world have really developed out of the same idea that existed in Britain before the NHS, which is an insurance-based system. And when we look at international human rights documents, they are agnostic about whether you have an insurance-based system or whether you have an NHS style system, or what we might call a Bismarck system, named after the old German Chancellor, Otto von Bismarck, who set up the first health insurance system in Germany that, in fact, the National Insurance Act was modelled on. Or we've got the Beveridge system, named after William Beveridge, who said that a comprehensive free health service should be part of the new structure of the welfare state after the Second World War. So after the Beveridge report, you've got the an NHS style system. So you've got Bismarck systems, you've got Beveridge systems. And international law is agnostic about which one you have, so long as you comply with rights as follows. So the Universal Declaration of Human Rights in Article 25 said that everyone has to have the right to a standard of living adequate for health and well-being, including medical care and necessary social services. And so what this isn't saying directly is that the government has to provide healthcare. What the government has to do ensure that everyone has a standard of living necessary to have health and medical care. And it's not saying how that should be provided. Right? So everyone has to have access to medical care. The European Social Charter is similar, reflecting the diversity of healthcare systems around Europe. Article 11 talks about preventative healthcare. Governments have a duty to remove the causes of ill health, things like an epidemic breaking out, accidents. Article 13 says if people are without resources sufficient to pay for healthcare, should they need to pay for healthcare, then adequate assistance and care has to be provided. So that's the social safety net, which is pretty much the same as what the Universal Declaration is doing. And we see that in the International Covenant, Economic, Social and Cultural Rights of 1966, which, as you remember, codifies and puts into a treaty the principles of the Universal Declaration. So it says that government has a duty and everyone has a right to the highest attainable standard of physical and mental health, including the creation of conditions which would assure to all medical service. So, it's agnostic about whether you've got a Beveridge system or Bismarck system, but international human rights law is not agnostic about whether or not you cover everyone, whether or not health is universal. So that brings us to what we can mention now, the third kind of system, which is a broken system, which does not guarantee universal coverage. And of course, the most salient example of the broken system is the United States of America, which still fails to guarantee universal healthcare coverage to everyone. When we look at the European Convention and the Charter of the European Union, Charter of Fundamental Rights of the European Union, it's much more minimal when it comes to healthcare. In fact, it's not really there in a significant way at all. But for our purposes, it's relevant just to touch on a couple of things. So Article 2 says that everyone has the right to life. Articles Article 3 says that nobody should be subjected to inhumane and degrading treatment. And Article 8 says everyone has the right to a private and family life. And as we'll see, this comes into some of the cases in healthcare later on. But the standards are such at a bare minimum, unlike the International Covenant. And then you've got the Charter of Fundamental Rights, which pretty much says what the International Covenant says, that there's a right of access to preventative healthcare and the right to the benefit of medical treatment by national laws. So agnosticism is the name of the game in international human rights law. And it seems to be the same, this kind of pattern of agnosticism in the United Nations Sustainable Development Goals, and in particular goal number 3, which deals with what the healthcare outcomes ought to be if we are successful as a planet in human development by 2030. So the overall goal is to ensure healthy lives and promote well-being for all at all ages. It sounds a bit similar to international human rights standards, but when we look at the details, the ambition is somewhat lower. So the goal for maternal mortality, women who die in childbirth, should be under 70 per 100,000 women who give childbirth. Just by comparison, in the UK, it's 9 women who die in childbirth out of 100,000. So 70 is an enormous number. And of course, 9 is an enormous and unacceptable number. And we want to get it ideally down to 0. The world was at 216 in the year 2015. Then there's neonatal mortality. So that's children just born or deaths of children just after birth. And the goal is under 12 per 1,000 live births, and for under 5s it should be under 25. The UN wants to end epidemics. Of course, we've had COVID. That did not go that well, but of course, there's only a certain amount you can do depending on the severity of the epidemic. But the things that we can that we know how to solve, like AIDS and tuberculosis, malaria, or reducing hepatitis. I mean, this is certainly something which is achievable. Reduce cardiovascular cancer diseases, cancer, diabetes, respiratory diseases, and suicide. Prevent abuse of drugs and alcohol. Halve global road deaths. Ensure sexual health care and contraception is available to everyone. Have universal health coverage and reduce death and illnesses from chemicals, air, water, and soil pollution. And those last ones, probably from 4 up until 9, don't just depend on what we do, of course, with our healthcare system and what we're going to be talking about today. They also depend, crucially, on the regulation of energy supply, and whether it's fossil fuels and causes toxic pollution in the air of all of us and in children's classrooms and in the lungs of young boys and girls. It depends on the food that we eat and food regulation, and water regulation and how clean it is and how healthy it is. Have we got food that's full of fat and sugar and salt, or do we have people eating food most of the time that is healthy and wholesome? It depends on transport regulation. Road deaths can be severely limited or drastically reduced if we have more investment in better roads. But also there's this huge issue that we've got coming in the next decade or so, no doubt, of autonomous vehicles, and whether driverless vehicles can be significantly more safe than vehicles that human beings drive. Okay, so those are the Sustainable Development Goals. So although human rights and the Sustainable Development Goals are agnostic about which kind of system that you have, so long as it's ensuring universal protection, I think it's important to probe whether international law and lawyers in general should be agnostic about the kind of healthcare system that we have, the financing and its governance, because we can see very big differences in outcome. So before we understand those differences, it's worth understanding some of the theory about why it is that so many countries have an NHS-style healthcare system, or they have a public insurance system, and they don't just leave healthcare to the market. And I think that there's a huge number of reasons. So let's just go through a few of the main ones. The first is that if you leave healthcare to the market, it's very likely to systematically fail because doctors and hospitals or health organizations have drastically unequal bargaining power compared to patients. So this is John Stuart Mill's version of a natural monopoly or a skill-based monopoly. Doctors have to invest or have to have rather a lot of training to acquire the skills in order to be able to treat patients. Not everybody has access to the skills. Indeed, not everybody can be a doctor, even if they wanted to, because it takes a particular kind of eye and talent to be good at doing medicine. So these skills are rare, and that means that if doctors are able to charge whatever they want for their services and they can organize into firms, then they will have very unequal bargaining power and prices will go up and up and up if you just leave it entirely to the market. Second thing is that there's a general failure of competition in healthcare, because what you need is the opposite of competition to run a good healthcare service. There are many ways in which we can understand this phenomena, but just for one example, healthcare and knowledge about what to do to ensure that people have good medicine depends on networks of people sharing knowledge amongst medical professionals who need to cooperate in order to spread the best practice. So if you have a competitive service, that can certainly get in the way of cooperation. Competition fails, therefore, to deliver the best possible outcomes. Cooperation is the best way to achieve good outcomes in this sense alone. There's huge information asymmetries between the doctor and the patient, or between the insurance company and the patient. The doctor knows what you need. You probably don't. Every time I go to the doctor, I am entirely in their hands. I have no idea what I need. And you need to be able to trust your doctors. And so if you have that kind of information asymmetry, then it's impossible for patients to act as consumers and sort of shop around for the best available services, because they don't necessarily know what they're looking for. Then we've got this public good phenomena, which is specific really to the provision of public health. So not necessarily patients receiving services from hospitals and doctors, but measures by government to ensure that diseases are not spread. So if enough people are vaccinated against COVID, for instance, then that has a positive external effect on everyone, even those who are unvaccinated. The herd immunity, remember that term, the herd immunity that everybody gets from being vaccinated against COVID or rubella, mumps and measles, or anything else against the flu, it is a good which is non-rivalrous and non-excludable in economic terms. So it's a public good, and that means that because private parties won't be able to capture the benefits of it, there is a likelihood that people will private actors will underinvest in the things necessary for the public good. So the logic goes, we need public provision of public goods at the very least. Then there's externalities. So just one example, if you have drug companies and doctors that are motivated by profit, then they will have an incentive to overprescribe drugs. And this can lead to all sorts of terrible outcomes. The most salient, most obvious one is Purdue Pharma, run by the Sackler family, which has did engage for many years in the marketing of vast numbers of opioids, which get people hooked on opioids, and this has led to an appalling opioid epidemic across the United States. And that has external effects that the private drug companies don't pay for, namely poor health, people not being able to work, or ending up very sick and dying. And then there's also a macroeconomic market failure. If you have poor health, if you have people who are sick, that's going to lead to more unemployment, people losing time at work because of illnesses. Okay, so let's just look now at some comparative data that we've got across OECD countries on life expectancy and health spending. So that's what this chart shows. On the x-axis, you've got life expectancy in years from age 73 up until age 85. And on the y-axis, you've got spending in US dollars per capita adjusted for the purchasing power index. Purchasing power parity index, and the base year for the value of the US dollar is 2010. And the dots are all different countries, but the dots have different colors. So you should be able to see that you've got green dots, which refers to a country which has a public insurance system. And then you've got a blue dot, which refers to a country which has a single-payer NHS-style system, so what we call a beverage system. If it's a yellow dot, then it's a mix between a public and private insurance system. If you've got an orange dot, then it's a private insurance system, but one that still ensures universal healthcare. And if you've got a red dot, you're America, and you've got a broken system which, unlike every other developed country in the world, fails to guarantee universal healthcare to all people. So already in 2010, you can see that America is the extreme outlier. What we want to be, really, if we want to have more life expectancy, is we want to be, and for cheaper prices, we probably want to be like Japan or possibly Spain. Switzerland is also doing very well, but in its private insurance system, it's paying, more than double what Spain is paying per capita, or around double what Spain is paying per capita. But now the really interesting question is how this changes over time with all of the different things that are going on in the restructuring of different healthcare systems. And I also want to point out, although it's cluttered, just in the middle, around here, it's obscured by Finland somewhat, but there's the United Kingdom. There's New Zealand, there's Finland, there's the United Kingdom. They've all got NHS style systems. And the interesting thing is how this moves over time. So that's 2010. And here's 2011 and 12 and 13, 14. And by this point, I should add that the UK's 2012 Health and Social Care Act reforms have started to kick in. And watch the UK going backwards and getting more expensive nevertheless. Look at America right at the top, just before it disappears off the chart because it's so expensive and still has a life expectancy that is below the vast majority of Europe. 2018. 2019. Look how much the UK's healthcare costs have gone up, and yet life expectancy is almost stagnant. And of course, 2019 is the year before COVID, where everything goes backwards and a little bit haywire. It goes backwards again in 2021. In 2022, the statistics start to recover, and that's where the data set that I've got has ended. And already in 2022, it's incomplete. But so if we just look at that again, you can see now Switzerland is slightly ahead of Spain, but again is paying almost double the amount that Spain is paying. If we go back here, we can see that and in fact, right throughout in 2021, we can see that Japan is ahead. So there it is, approaching 85 years just before COVID. And if we rewind, really you want to be Japan. Or I think that you want to be Spain. But of course, we know that there are lots of other things that affect healthcare outcomes. If you're in Japan, quite sunny, got a lot of sushi, got a lot of healthy food, rice, good diets generally. If you're in Spain, you've got a lot of sun. People are generally going to be happier, pretty good food. In fact, all of the countries around the Mediterranean that you can watch will have similar advantages. Northern European countries less so. But the really interesting thing for us is what is it in the details of each of these countries' healthcare systems that determine their trajectory. We can see very clearly that the more you spend the more money that you put into your healthcare service, the more life expectancy you're going to get. But we have also got to be mindful of the fact that the countries with mixed systems or privatised systems seem to be spending a significant sum of money extra. It's fully public systems with the blue dots, or it's the public insurance systems with the green dots that appear to be doing the best on the whole. Now, this is just a scatter plot moving over time. It looks nice. What we really need is a full econometric study that shows empirical evidence, how different that measures empirical evidence through changes in the law mapped onto changes in outcomes like life expectancy and cost of healthcare. So we need regression analysis and econometric methods to get a better answer. But this is already interesting, and we can tell a lot just through looking at it. So now we need to get into the details of the health service, and we'll start with finance. Okay, so for finance, what we need to look at are five main things. Most funding for the health service in Britain is public funding through taxes. Second, we'll look at the sources of private funding. Thirdly, the charging of NHS patients and foreign patients. Fourthly, for the drug companies, they get a lot of their finance from having patents or intellectual monopoly rights. And fifth, for the health service to run well, it's ideal if nobody gets sick in the first place. So an important source of finance and saving money is preventative health measures, or what we call public health measures. So first, the public funding. Under the NHS Constitution for England, written by the Department of Health, Principle 2, the famous one, says that access to NHS services is based on clinical need, not on an individual's ability to pay. There is a huge amount of money spent on the health service, 20% or a little bit over of the budget for 2026 to 2027 will be for healthcare, £294 billion. And the costs have been rising from 4% of GDP in 1970 to 10% in 2018. And now in 2024, the last statistics showed 11.1%. This might go down as the effects of COVID recede. The chart below that shows the sort of flow of money. So you've got the Treasury, first of all, giving money to the Department of Health. And then the Department of Health used to give money to NHS England, or still does, but the NHS England is an arm's length body that's being remerged back into the Department of Health. So probably the Department of Health is just going to take over its functions so that they don't need to be duplicated. It gives money to specialist doctors. It also gives money to external regulators, the National Institute of Clinical Excellence, which approves drugs. Don't worry about NHS improvement, that's gone. The Care Quality Commission, which inspects hospitals. Health Watch, which is supposed to be a forum for patients. But then most importantly, it gives money to integrated care boards, or the ICBs, which in turn pass money on to NHS trusts and particularly foundation trusts. Can also give money to private companies, GPs as well have funding from integrated care boards and the Department of Health alike. So that's the sort of general flow of cash. But we also know that apart from public funding, there's a significant amount of private involvement. And the really big change was the Health and Social Care Act 2012. It amended the National Health Service Act to 2006, Section 43 2A, which had limited the amount of money that NHS trusts could generate from private work to 2%, but that cap was raised to 49%. Good question about why any private involvement is being allowed at all. Now, in fact, most NHS trusts, most NHS foundation trusts won't be anywhere near 49%. Most will a vast majority will still be at or under 2%. But a significant number of the London hospitals, where you've got specialist centres, do a lot of private work. And so what it means is that you can walk into a hospital and a surgeon who tells you that there's a waiting list on the NHS will also tell you, but I can treat you privately if you pay me a lot of money as an external specialist. And the real problem with this is it's taking away expertise from the public service, and it's putting it straight into the pockets of incredibly well-paid surgeons and doctors or other specialists that already on the NHS are being paid far beyond salaries far beyond what most people will ever earn. Okay, so that's a real problem, and it's certainly grown with the 2012 Act. An important thing that was repealed was the NHS Procurement, Patient Choice and Competition Regulations 2013, which had said that there had to be equal treatment and non-discriminatory treatment of providers on the basis of ownership, so you couldn't discriminate against private companies. That has been repealed, but you still got private companies there. And we know that when private companies run NHS services, they've generally done an absolutely abysmal job. There are stories that can be told about InterHealth Canada running a service in Runcorn. There's the Circle Group, which was set up by some Goldman Sachs executives who ran a Cambridge at Hinchinbrook near Cambridge that was so bad that the Care Quality Commission rated it as not up to standard, and it had to be taken over again by the public service because of the appallingly poor provision of patient care. So a lot of money is spent for private healthcare, but it does not solve the system problem of how you get good quality healthcare to most people most of the time. There's also a lot of private involvement through building. And this is the National Health Service Private Finance Act of 1997. Section 1 says that there is a right for trust to borrow privately. The Secretary of State can approve, and a lot of new hospitals were built through the Private Finance Initiative because it meant that the government wanted to encourage this because it meant that in order to get more investment, you didn't have to have the government do borrowing, which puts up government debt. If you had the building of a hospital and then the private company runs the hospital and charges rent for, let's say, 25, 30 years into the future to the NHS, then those future rent payments are not seen as debt and it doesn't add to the government debt. So it looks good as a simple accounting trick, but the long-term costs of the private finance initiative have been astronomical. So one calculation or one estimation is that private finance built hospitals cost £80 billion more than they would have done if they were just funded through government debt, and not worrying about the perception of adding to government debt. Which really doesn't matter at all, except for, in the minds of the Chancellor and accountants who support this. Then we've got actual private health insurance. And there is a really significant number of people covered by private health cover. Often it's through employers who offer private healthcare plans, but always, or most of the time, this is supplementary to the general NHS system. So it's not like other insurance systems where a private insurer will really cover you for everything. People who've got private coverage in the UK also get access to NHS services, and 11.8% of people are covered in the UK through companies like Vitality, Bupa, Aviva or AXA. But really it's often doing things like giving people, a gym membership, or there'll probably be dental care, there'll probably be optical care, things that aren't covered on the NHS, and maybe some specialist services, some ability to bypass waiting lists. But the growth of this sector is really just on top of the NHS, and highly problematic in the amount of fees that they charge for the very little service that they actually do. Now, then we've got charging of people within the NHS, and we've got charging of foreign patients. So the NHS Act 2006, sections 172 to 181, have a group of exceptions from the general principle that the NHS has to be free at the point of use. So they can be, famously, charges for dental care, optical care, and then there are prescription charges for drugs or medicines, appliance or pharmaceutical services, unless people qualify for reimbursement of costs. Now, Nye Bevan, the Minister of Health, famously resigned over the introduction or reintroduction of charges for dental and optical care. Many countries who have NHS systems ensure that these things are heavily subsidised or free at the point of use in the basics. And of course, we can always get better glasses. A public health system doesn't need to pay for super expensive designer glasses. There's a certain amount of cosmetics that are available in dental care that don't need to be provided. But the important thing about the NHS is it still hasn't got basic provision for many, many kinds of things that are seen essential for dental care and optical care. There's still quite a lot of charging going on, even if it's an NHS dentist. Then there's prescription charges. Scotland doesn't have them, but England does. Now, another form of charging in the NHS is under the 2015 Charges to Overseas Visitors regulations. And regulations 3 to 9 says that there's a duty on NHS trusts to charge non-residents for healthcare, except for emergency treatment. There's a duty because the government wanted NHS trusts to charge people, and NHS trusts found that somebody comes in need to a hospital, it was much, much cheaper to not fill out all the forms to try and recover money from them, but just to treat them. And people had protests saying, I'm your doctor, not your accountant, we don't want these charges. But the Conservative government, in its wisdom, decided to mandate that NHS trusts had to charge foreign patients, largely because of campaigns led by newspapers like the Daily Mail about benefit tourists and foreigners taking advantage of the NHS, even though the scale of the problem is absolutely minuscule. When British people travel overseas, if it's in Europe, there is a bilateral or there's a multilateral treaty that ensures that you get the right to assistance. And the same is true when people from Italy or Germany come to Britain. If they get sick and they need care, then the European Convention on Social and Medical Assistance, 1953, says that there is an equal right to assistance. And costs should be covered in an equivalent way or equivalent to any other person would be within the member state if somebody is without sufficient resources. So there's charging of patients outside the European rules. Now, a fourth area of money-making within the health service is from the drug companies. The drug companies were not taken into public ownership. There are very, very large drug companies which operate on a global basis, and most of these make most of their money through patents, often called intellectual property. But I think that's a little bit of a misnomer, because what a patent does is it gives you monopoly rights over a thing that you hold, a patent on an invention for 20 years. So the Patent Act in the UK, 1977, under Section 1, says that you can get a patent if you've made something with an inventive step capable of industrial application. And Section 25 says that a patent lasts for 20 years from the filing dates. There's an international agreement called TRIPS under the World Trade Organization's auspices that says similar things, and there's also a European Patent Convention. And if we look at the top 10 drug companies around the world, as I say, much of their money is being made from holding these monopolies, but they even with those monopolies, there is a pretty intense concentration of market share. So the top 10 drug companies hold 45.3% market share, at least in the latest available statistics that I could find in 2022. And this market share, the global market share, is rising. Companies like Pfizer, Johnson & Johnson, absolutely massive. And most of their profits are held through having these monopoly patent rights. And I think it's important for that reason to interrogate why you can get a monopoly right on an invention, specifically when it could be about a life-saving drug or drugs that are essential for people to live with good health. And the main argument is that you need to give patents on drugs in order to incentivize innovation and to protect and properly remunerate the person who invents whatever is subject of the patent. But there's at least three problems with that, particularly in the context of healthcare, which means that this argument, I think, simply does not work. The first is that a company that holds a patent will take the rewards and the monopoly profits from the patent, but the company is not the thing that invents the drug. It'll be the employees of the company that have invented the drug, but the employees don't get to hold the patent. It's their employer that does. And so they are not getting any of the profits from the drug. They will get a salary, maybe they're getting a bonus, but there is a complete disconnect between the person who gets rewards and the person who does the actual inventing. Second thing is that development of drugs, quite apart from the invention, but the development of drugs that can be subject to the patent is usually funded by the public sector, or it's done through publicly funded universities. And we can see that very clearly with the COVID vaccine. The vast majority of successful COVID vaccines from Pfizer, from AstraZeneca, Moderna, were made with public money. So the Pfizer vaccine really came out of the Max Planck Institute, a publicly funded research institution in Germany. The AstraZeneca vaccine came out of Oxford University before they partnered with private companies that hold the rights and develop and distribute the drugs. And the third reason why the patent argument doesn't really work in the case of drugs, and perhaps the most important, is that profit is simply less important than people's lives. And wherever having international monopolies on life-saving drugs could limit access to people's health, then the principle of protecting profits surely has to give way to making sure that people's lives are saved. And that can be done in a number of ways. One is by limiting any number of years that there are for patents. Another one is just allowing immediate production of generic drugs, so long as some kind of system for a reasonable return is given to the people who invent. Certainly 20 years is a huge amount of time, particularly when you're facing something like an AIDS epidemic and people need antiretrovirals right now in order to save lives. Now, the fifth area of finance that we need to inquire is what can be done to protect public health, because the NHS spends so much on very, very similar causes of ill health that could be prevented with public health interventions. So the NHS is almost negatively financed by the lack of public health measures. So just to give you the top three, the leading causes of death in the UK are from dementia and Alzheimer's, and that one is intrinsically related to old age. There's a long discussion that we could have about preventing dementia and Alzheimer's, but the answers are not so straightforward, and of course everybody gets old and will die at some point. But then the second and third one are really, really different. So we've got heart failure as the second leading cause of deaths in the UK. And heart problems, we know, are hugely exacerbated by fatty foods, sugary drinks, and this leads us into the regulation of very large restaurant and supermarket companies that provide poor quality food and drinks to people. So Tesco, Sainsbury's, KFC, McDonald's, Coca-Cola, Nestle. if they were regulated in a different way, then many of the problems of heart failure could potentially be avoided. And the third leading cause of death is lung failure. And of course, that is driven dramatically, or to a great degree, by air pollution. It's also about other things, smoking in particular, but that leads us into looking at which of the companies and which of the problems in the law which cause air pollution and therefore lung failure. So Shell, BP, Volkswagen, the big oil companies, the big car companies, and then of course you've got tobacco companies like British American Tobacco, Imperial, and so on. All of these companies could be regulated in a different way, and therefore massively decrease the amount of lung failure that the NHS has to treat. Under the NHS Act, however, the NHS does not have power to introduce public health measures. It deals with the consequences, but it doesn't have power to deal with the causes. It's the Secretary of State that is in the lead for taking public healthcare measures shared with local authorities. But what is really not there is some system for the NHS to propose and to implement public health interventions that could really make a big difference to the problems that they see every day. The Secretary of State can delegate to agencies such as the UK Health Security Agency or the Office of Health Improvement and Disparities. This is all in the section 7A of the NHS Act 2005. And I think it's just worth comparing the NHS system very quickly, or in broad summary, to what happens in an insurance system. And I've chosen Germany not because it's the best, but because there's quite a lot of information about how the German system works, and it's the biggest country in Europe. So unlike the UK, Germany has an entire codification of its welfare state, known as the Social Code or the Sozialgesetzbuch. And in the fifth book, it is devoted to the regulation of healthcare. Paragraph 1 says that health insurance is a community of solidarity with the task to maintain, restore or improve health, and insured persons are jointly responsible for their health along with the insurer. Paragraph 3 says that benefits have to be financed by contributions, but the family of the insured do not pay. Paragraph 4 says that health insurance funds are corporations under public law, and there are 6 fund types: general, local health funds, company health funds, guild health funds, farmer funds, pensioner funds, substitute health funds. So you have to sign up to one of these health funds in order to get health insurance. One of the big ones, for instance, that many Germans will know is the Technische Krankenkasse, but it could be anything. It could be a state fund, it could be a federal fund, and you can choose where to go. Many will be publicly organised, some will be charitable, a small number will be private. But this is a competitive system, and so you get health insurance, and the health insurance is separate from the hospitals and the doctors that end up doing the treatment. And they can be organised in all sorts of different ways as well. They can be private, they can be charitable, they can be organised by states. Paragraph 4A says that there has to be fair competition, and advertising is regulated by the Ministry of Health. And so what we see there is exactly the sort of thing that the NHS tried to experiment with, competition, and before moving away from it again. And so you've got this ethos of competition within the German insurance system. Paragraph 5 says that there's a duty to be insured, so that is key to ensuring that there's universal health coverage. But there are some exemptions in paragraph 6 for certain professions, religion, in religion or in the judiciary. Paragraph 12 says that benefits must be sufficient, appropriate and economical, and no health insurance claims that aren't necessary are allowed, so you're not meant to make frivolous claims. Paragraph 20 says that health insurance funds also have preventative duties to promote healthy lifestyles and reduce inequality. Similar to most countries, like NICE in the UK, new drugs have to be approved by a federal joint committee. So 10.5% of people in Germany have private healthcare. The rest have charitably organised or publicly organised healthcare. But I think the crucial thing to see is that this is a system where you have insurance that still has competition at the heart, and also you will have separate hospitals and doctors which are not organised in an integrated way, that are carrying out health service separated from the insurance that people have to pay for, not funded through the tax system, funded by insurance premiums. So next we get to governance. So under the governance of the health service, we want to look at a few different actors and how they're organised. The Department of Health, NHS England, which, as I say, is going, integrated care boards, NHS Trust, GPs and specialists, NICE, the Care Quality Commission, Social Care and Homes, and then the World Health Organization. So first, the Department of Health is the department that sits under the Secretary of State, and under sections 1 to 1C, the Secretary of State has a duty to improve the National Health Service, pay regard to the NHS Constitution, and reduce health inequalities in England. It had been thought that an extra bureaucracy by the Conservatives, known as NHS England, would be a good thing to take power away from the Department of Health. In practice, it's just replicated most of the work the Department of Health has done, and now NHS England is being merged back into the Department of Health. So then money will go from the Department of Health directly to integrated care boards, currently and until 2026, running through NHS England, but soon it'll go directly to integrated care boards. And under Section 3, they have duties for maintaining hospitals or funding hospitals, medical services and nursing, but not, by and large, general practitioners, although they may have some role. Integrated care boards have duties to uphold the NHS Constitution. They have duties for efficiency and to combat inequality. So it really matters how they are appointed. And the answer is it's still pretty top-down. They are appointed by the Secretary of State. However, 3 members of integrated care boards, although they have to be approved by the chair, can be nominated by NHS trusts, which probably means the management of the trust, staff or people, as it's put in the statute, who provide primary medical services, and local councils. So there's some kind of voice or some indirect, very weak link between the voice of staff and local authorities who will represent patients, but not that much, and it's still really top-down Whitehall control. Then we've got NHS trusts that can carry out work, and if you're a good trust, you can get foundation status. Trusts are appointed, the heads of trusts are appointed by the Secretary of State through order, through an order of the government. NHS foundation trusts, however, have got more autonomy. So they have a council of governors, and between 3 persons or up to 49% of the governing body of an NHS Foundation Trust may be elected by the staff. That was an innovation from the former Health Secretary under the Labour government, Alan Milburn, who looked at the Spanish system and thought that more democracy in the NHS would be a good idea. There's some representation for local councils, and if you've got a university in the area, then the university also gets an appointment. So to give an example, if you've got King's College London, which is in the area for the Guy's and St Thomas's NHS Foundation Trust, King's College London is appointing 1 person to the board of, or the governing body of the Guy's and St Thomas's NHS Foundation Trust. So again, there's some representation here, but it's still majority top-down, and there's less involvement, less voice for the staff, for patients and local authorities than you might hope for. And also when it comes to who's appointed by universities to an NHS Foundation Trust Board, that's going to depend on how democratically organised the university itself is. And often you can get just a sort of rotating group of people who are used to picking up board seats on lots of things because they're on lots of boards, and then they go on to other boards. Then we've got general practitioners, which are not formally part of the NHS structure, but they're certainly funded by the National Health Service. General practitioners are usually partnerships, or they might be companies, but they will operate independently, but they get paid through what is effectively a collective agreement put into statute known as, they have terms settled by the NHS General Medical Services Contracts Regulations 2015. There's a range of things that we could talk about here. Just one that's useful to mention is under Regulation 26, GPs have to have a patient participation group to consult patients on the way that they deliver their service. But it's only consultation and it can be ignored, so not much formal voice for patients. And this is some distance from what the founder of the NHS, Nye Bevan, had originally envisaged. So in a book called In Place of Fear, Bevan put the case for more industrial democracy, or more economic democracy, democracy at the workplace, democracy at public services. The persistence of a sense of dualism, he wrote, or distance between staff and management in workplaces, in a publicly owned industry as well, is evidence of an immature industrial democracy. The individual will still feel that society is on top of him until he's enfranchised in the workshop as well as the ballot box. Democracy is protected by extending its boundaries. And when it comes to the NHS, when he was thinking about the details of this, he said in Parliament, "I believe it is a wise thing to give doctors full participation in the administration of their own profession." So let's just broaden that to the nurses and the specialists who work in a foundation trust. He thought that it would be a good thing for these experts to have more voice in things like who's on the governing body of the hospital. They must, of course, necessarily be subordinated to lay control, so elected representatives and the voice of the public. We do not want the opposite danger of syndicalism. So, obviously there is a problem in any governance system to balance the voice of the relevant stakeholders, the workforce, the investor, which in this case is the public, and patients. And you don't want any one group to necessarily dominate another. But the system that we've got at the moment does involve a management group, an internal elite often, or the Secretary of State top-down approach from Whitehall dominating other stakeholders. And that probably leads to suboptimal governance outcomes. Now, then there's another group of actors who we can put together under the label of the regulators. They all do different things. So the National Institute for Clinical Excellence approves medicines and drugs before they're sold. So the days of the carbolic smoke ball company are gone, where anybody can sell poisonous, toxic drugs on the market. And then the only thing that you have is a case in contract law, which probably doesn't work that well. No, drugs have to be approved before they are sold or given to patients to make sure that they work and they don't make people even more sick. We've got the Care Quality Commission, which inspects hospitals to ensure that standards are maintained. So, if you think of the case of Circle in Hinchinbrook and its failures there, well, the Care Quality Commission played a lead role in shutting it down. You had NHS England, or you will have NHS England up until 2026. There was a service called, or a body called NHS Improvement or Monitor, which is being merged back into the Department of Health. And then finally, we've got NHS Resolution, also known as the Litigation Authority, but NHS Resolution is its sort of brand name, that really deals with medical negligence claims. And that's something like 3 billion or over 3 billion pounds a year paid out, which is quite a lot. Now, another part of the health system, but not integrated into the National Health Service, is social care homes. And I say that this is part of the health system because particularly when we're talking about elder care or disabled care, the care system is intrinsically intertwined with people's healthcare problems because particularly elderly people have very serious healthcare needs. But it is separate and it is very, very poorly functioning. And the reason for that starts with the fact that the National Assistance Act of 1948 gave councils a duty to accommodate and give services, care homes for instance, to people, but they can charge. And that's where everything has gone wrong. If you're a local authority under the Chronically Sick and Disabled Persons Act 1970, there's also a duty to meet the needs of people, give assistance at home, recreation, comfort, meals and communications. The Disabled Persons Act 1986 says councils need to assess the needs of disabled people and respond to requests. And so for the most vulnerable people, there can't be charges, but for others, there can be. The Care Act, sections 8 to 20, led to a debate about whether there should be some kind of cap on the amount that local authorities can charge people for care homes, but it was decided by the Conservative-led and Liberal Democrat coalition that even a cap of £72,000 a year was not going to be put into the law, so people can lose everything when they have to go into care in old age. The Care Standards Act 2000 in sections 1 to 11 sets up a system of public oversight, but the inspections are very loose, and so we see many cases of really, really poor standards in care homes. Just one example is a case called YL and Birmingham, where a business called Southern Cross was held to not be a public body and therefore not subject to standards in the Human Rights Act, so it could eject an elderly person with just 28 days notice from the care home. Southern Cross was an appalling company. It went into administration in 2013 and it was found to have been systematically mismanaged and abused the elderly people that it was meant to be caring for. Final actor is the World Health Organization, and I think this is just worth mentioning because, of course, what happens in Britain and the health of Britain, and we know this particularly since COVID, is intertwined with the health of everybody on this planet, not least through communicable diseases. So the objective of the World Health Organization is, unsurprisingly, the attainment by all peoples of the highest possible level of health. It is run through the World Health Assembly, which has 194 member states, and it's meant to assist governments, provide technical support, and foster cooperation in research. But the World Health Organization has been under attack. So it has budgets that last for 2 years. In 2024-25, it had a budget of $6.83 billion US dollars, but largely because of the attacks by Donald Trump. In 2026-27, it's cutting its budget to $4.3 billion. Trump withdrew from, or wrote an executive order the moment he got into office or seized power again, saying that he was withdrawing from the WHO. And the United States will no longer be contributing to it, even though Americans get just as sick from global pandemics as everyone else, but has a healthcare system that is considerably less capable of dealing with it. There's no role yet for the WHO in doing sort of more positive things. I mean, really at the moment it is struggling to survive on a threadbare budget. I mean, if you think of a planet of 8 billion people, a budget of $4.3 billion US dollars is not very much at all. But, you know, I think it's useful to think about things that it could be doing in the future. It could be fostering bilateral healthcare treaties to facilitate free movement of people, ensure that people can get healthcare on a reciprocal basis wherever they go around the world. The European Convention that we have had since 1953 could be a model for that. It could be promoting best practice in the governance and the finance of healthcare system, making sure that there is, or helping governments set up universally funded healthcare systems. The funding that it does give out is broken down as follows, or I think these statistics are from a few years ago, but it gives you a sense of the priorities. So the WHO spends money on eliminating communicable diseases, on non-communicable diseases like polio, maternal, child, elderly health or health systems, or contingency funds for emergencies. And finally, we get to the rights, or the enforceable rights in the healthcare system. So the right to treatment, whether you can access healthcare, issue of waiting times, whether you've got equal treatment, medical negligence, or conflicts of interest. So let's start with whether there is a right to treatment, or whether there's a right to medical care. And the answer is that the way that we ensure you get medical care is through the public funding and the governance of the NHS. That is what has ensured that everybody has access to, that universal healthcare is provided in Britain. It has not been through private litigation and private rights of action in contract tort or whatever else. And we have a number of cases which defer to the fact that it should be for decisions of the health service and not for litigation to ensure that care is provided. So a few cases that bear this out. The first one, pretty heart-wrenching, is a case called B and Cambridge Health Authority. And this was about a poor little child who needed a second bone marrow transplant, or rather claimed, or his parents claimed, that he should have a second bone marrow transplant for the condition, the life-threatening condition that he had. He'd already had a first bone marrow transplant, and the health authority thought that he was going through so much pain, it was so agonizing, that it just was very unlikely to work, so that he should not get a second one. So the Cambridge Health Authority refused a second one. The parents, of course, as all parents would be, were absolutely distraught and heartbroken, and they went to the newspapers. And the newspapers, like The Sun and the Daily Mail, who were really leading a campaign against the NHS itself, campaigned for this child to get a second bone marrow transplant, and said that they would pay for it to be provided privately. And the subtext of their campaign was that the NHS is terrible, you can't have a publicly funded healthcare system, it's bad, we should have more private care because look how bad the public system is. This is in 1995. Now, the High Court held that the health authority, when it said that resources were limited and therefore it didn't think on balance that it should provide the transplant, it said that the health authority was wrong, and that they acted outside of their lawful discretion. It cannot just toll the bell of tight resources, said the High Court. The Court of Appeal disagreed, overturned the High Court, and said that using a limited budget to the maximum advantage of the maximum number of patients is a judgment for the health authority, and it's not a judgment which the court can make. It should be a specialist decision, and therefore the court should not interfere with the discretion of the health authority, except in the most serious and obvious circumstances, because it should be a judgment for health professionals, not the court. And the tragic end to this story is that the newspapers their campaign did in fact lead to a private specialist being found who performed an experimental operation, and it didn't work, and soon after the child died. Coughlin is the next case, and North East Devon Health Authority. This was about a road accident victim who had been left tetraplegic, and they had been promised a home for life by the local council, the North and Devon, East Devon Health Authority. But then the home was closed based on the idea that it was just going to cost too much. So could Coughlin claim, given that she'd been promised a home for life, that the health authority had acted unlawfully? And the Court of Appeal said yes, it violated a legitimate expectation of Coughlin, because when you promise that somebody's going to get a home for life, this is equivalent to a breach of contract, even though there's no consideration when a public body gives an assurance that can be reasonably relied upon. This is equivalent to contract, and it's an abuse of power to withdraw the thing that has been promised. Third case on a right to treatment is Anne-Marie Rogers and Swindon Primary Care Trust. This was about Anne-Marie Rogers claiming that she should get a drug to treat breast cancer called Herceptin. The problem that she faced was that it hadn't yet been authorised by NICE, the National Institute for Clinical Excellence. And she claimed that this violated her right under Article 2 of the European Convention, right to life, by refusing to dispense Herceptin. The Primary Care Trust said that there weren't exceptional circumstances that should lead it to deviate to dispensing an expensive drug that wasn't yet approved by NICE. But the Court of Appeal said that a primary care trust or a health body can't just say that there's no exceptional circumstances, because that in itself doesn't explain why the circumstances aren't exceptional. You've got to give other independent reasons rather than just say you're not exceptional. And so it comes to the judgment that the primary care trust had acted unlawfully without, it said, the need to consider the right to life under Article 2. Next topic is waiting times, and I suppose this is really bound up with the question of whether people have the right to treatment, because in practice, if there are very long waiting times, then people aren't being treated. And the first thing I want to show you or point out is this chart from the Financial Times. It's a graphic put together by a journalist called John Byrne Murdoch, which shows that waiting times really do depend on the government that is in charge and the amount of investment that they put into the National Health Service. So under Thatcher and Major's government, waiting times skyrocketed. They were consistently brought down by a lot of investment under the Labour government. From 1998 up until 2010. When the Conservatives and the Liberal Democrats in coalition get back into power, they start cutting all of the public sector, the programme of austerity. NHS standards slip and slip and slip and slip, and waiting times skyrocket. And of course, right at the end, they go through the roof because of the COVID pandemic. So what we would expect to see with more investment in the NHS is very simply that waiting times go back down to where they were. And in fact, in the last year or the last 18 months, this is precisely what we've seen since the 2024 election. While Britain was a member of the European Union, there was a right to receive services in any member state, including healthcare services. So the Watts case was about somebody needing a hip replacement that cost £3,900 when they got it in France. And the Court of Justice said there was a right to receive services and the right to get reimbursed from the member state if you do need to go abroad for services because waiting lists are too long. So there are regulations passed after this case which narrowed down and said when, under what circumstances you could go abroad and seek help in another member state and then get reimbursed by the National Health Service. Of course, the need to travel abroad was vastly diminished after a case like Watts. Well, in 2006, it was already coming down dramatically. The facts that Watt faced were before the dramatic declines in waiting lists. And the Patients' Right Directive of 2011 codified the principles about when people can move to other member states to get care. So Article 4 talks about the principles of universality and that quality care should be provided. Core care has to be reimbursed, but member states can put reasonable restrictions on when reimbursements can be sought by people moving abroad to another EU member state for healthcare. Of course, now that the UK is outside the European Union, these rules no longer apply. Then we've got a group of cases about people being deported and whether this affects rights under the European Convention. So, you don't have a right to be treated in principle if you are a foreign national in the UK, and we've seen how there is a responsibility on NHS trusts to charge people. But in certain cases, people cannot be removed from the UK if they are facing really serious critical conditions. And that was the case in D in the United Kingdom. The Court of Human Rights held that if somebody is about to be deported, but they can't get any treatment to the place that they are being deported to, if death is imminent, then deportation will violate the right under Article 3 to against inhumane and degrading treatment. In N and the UK, however, you had a claimant with HIV who argued that they shouldn't be deported to Uganda. They argued on the same basis that it would violate their right under the European Convention, Article 3, if they were deported, because it was estimated that they only had or would have only 2 years left to live without proper treatment, and it was said that proper treatment was not available in Uganda. And the European Court of Human Rights hold that this is different to the D case where death was imminent. There is no duty on a member state of giving free and unlimited healthcare to all aliens without a right to stay. This would be too great a burden on the member state. And I think that we can legitimately question whether it is really too great a burden on an entire state to help somebody who is desperate and very close to death without access to life-saving medicine. However, there's no shortage of judges in the UK that have very, very who are not particularly charitable. Don't have that sort of mindset. One of them is Lord Justice Underhill. He says the UK does not have a responsibility for the inadequacy of the healthcare system in the country of return. But that's not really the point. The point is whether the UK's healthcare system is adequate to provide healthcare and life-saving healthcare to people who are in the UK. And the classic principle on which the NHS was founded was that it would give healthcare to everybody free at the point of need. And so erecting barriers to migrants if they happen to be in the UK is something that is antithetical to the principles on which the NHS was founded. Then we've got equal treatment. So the NHS Act, Section 1C, says that the Secretary of State has to have regard to the need to reduce inequalities between the people of England. The NHS Constitution, Article 1, says that there's a wider social duty to promote equality through the services it provides. And under Section 29 of the Equality Act, like with all service providers, the NHS, as a service provider, has a duty to not discriminate. And there are minor exceptions found in Schedule 3. So everybody needs to be provided access to healthcare equally. And of course, this is entirely consistent with the founding principles of the NHS anyway. Finally, we've got a couple of points to mention about negligence and conflicts. So I said this before, but worth saying again that the NHS spends a huge amount of money on defending medical negligence claims. That is largely manufactured through the tort system and through courts allowing claims. It's very unequal because a lot of people might not get sick and things inevitably will go wrong. Accidents happen within the health service, but the people who sue are often people who have access to lawyers to bring claims. And people who don't have access to lawyers won't or don't bring claims. So the NHS spends £3 billion on resolving medical negligence claims a year, or did spend that amount of money in 2024-2025. And the way that this money is spent, of course, could go to solving a lot of people's health problems and preventing accidents happening. But instead, the money is being sucked up through litigation and payouts by NHS resolution. An example of a case where the courts were not in favour of awarding a claim is Thake and Maurice. Kind of interesting set of facts. A man had a vasectomy, his partner, and he had sex, and unfortunately the vasectomy didn't work because the doctor didn't do the vasectomy properly, and they had a lovely new baby girl born called Samantha. And then they tried to sue the doctor for the costs of Samantha for the rest of her childhood. However, the Court of Appeal held that the parents could not sue the doctor in tort or contract. Yes, the operation went wrong, but sometimes operations do go wrong, and so a claim could not be brought just because it didn't go exactly the way that was hoped for. There was always some risk, and so there was no duty of care broken in tort or contract. Then we've got rules against conflicts of interest. So the General Medical Council guidance says that anyone with a financial or commercial interest in an organisation to which a patient is referred must not allow a referral decision to be influenced by their business connections, and the patient must be told if they are being referred to a place where the doctor has a financial or commercial interest. And that is designed, of course, to take conflicts out of the NHS system. But it is also completely clear that there are conflicts everywhere, whenever there is private work in the NHS system. So it is very common, as I mentioned before, that if you go and see a specialist doctor, they can tell you, well, there's a waiting list if you do this on the NHS, or you could pay privately, and I can do it for a very high fee, but within a shorter space of time. And so long as you have private work in the health service, that kind of problem is going to persist, where the rich can jump ahead in the queue of people who don't have the money, and that means that you've got a two-tier health service. Okay, so what kind of reform options could we take to improve the NHS, bring it up to the standards of the healthiest and best countries in the world, and also get a lot more efficiency, a lot more value for money in the health service to enable money to be reinvested and improve health outcomes of everyone? The first thing would be to shift the whole mindset of the health service to a preventative system. But that's a lot easier to say than do. Well, it's actually not that hard to do, but it does require a significant shift in the power to make rules over the causes of ill health. So the first thing that you could do by amending Section 7A of the NHS Act 2006 is you could transfer public health responsibilities from the Secretary of State to the National Health Service itself. And the second thing that you could do is that you could give the NHS rulemaking power on the regulation of food and retail, on air pollutants, on preventing obesity, on respiratory diseases and ill health in general. And there's a number of ways that you could do this. For instance, there will be an expectation on the Secretary of State when the NHS proposes rules to lay them before Parliament and take effect like any other statutory instrument, unless the Secretary of State has very good reasons to object. That's one way that you could do it. But one way or another, if you want to have really significant improvements in public health, you've got to let the NHS specialists say what are the causes and then tackle them directly. So that means fossil fuel vehicles, it means fatty foods, sugary foods, tobacco and alcohol. These are the main things that drive ill health, and so more stringent regulation needs to be introduced, whether or not this harms the profits of very large food and drinks and energy or vehicle companies. Second group of reform options concern the NHS's finance and governance. So first thing, with relatively low costs, Scotland does it, you could remove prices from prescription drugs. You could also remove prices from basic dental services. In fact, Japan is a really good model. One of the most significant interventions that Japan has made was to ensure that all elderly people have a full set of teeth, because so many health problems derive in old age, and they understood this from people not having working teeth. So if you have proper dental care for people well throughout their lives, but particularly in old age, that solves or prevents a huge number of other problems that can transpire later in life. So remove prices for dentistry, remove prescription drug prices, and give people a basic set of eye tests and glasses prescriptions on the NHS. Second, get rid of the private work or reverse the private work limits from 49% of NHS trust work down to 2%. That's what we did before 2012, so it can work again. Put a duty on private health providers that still exist up to 49%, so that they are mandated with their extra capacity to take on NHS work at a reasonable price if required. And then on governance, ensure that NHS foundation trusts and integrated care boards have up to 1/2 of their members elected by the staff, and then also secure representation for local councils or patient representatives. And then finally, in line with the Hippocratic Oath, make sure that nobody has to pay tuition fees to study medicine or nursing or dentistry, which is what you should be doing, getting rid of tuition fees under international law for all degrees at university anyway. And the final thing is that we could integrate health and social care. Start a new national care service joined up with NHS trusts, so that when people who are elderly and need care are discharged from hospitals, that the care service is talking to the health service. Ensure that people in the care sector are paid properly, so that we're attracting talent by ensuring that there's a nationwide sector collective agreement with fair pay scales for social care staff. And to the extent that there are still disputes over pay in the health service, for nurses, for doctors, make sure that there are multi-year deals so that everybody understands what the pay levels will be in the future, and therefore are encouraged to stay in the country, in the UK, so that doctors don't leave overseas because they're paid fairly here at home. Okay, so that is the health service and its reform.